All right, so quickly, what do we say the functions of the respiratory system are? All right, maintain homeostasis, okay. And what does that entail? Okay, so breathing to do what? Oxygenation and gas exchange, okay. So part of that gas exchange process is obviously the oxygenation aspect, pull oxygen into the blood, okay, but what else is going to go on there with gas exchange? CO2 leaves the bloodstream, okay, in the capillaries, and more specifically the alveoli. CO2 leaves the bloodstream and then is exhaled, okay, so that's our waste removal process. Also, we have acid-base balance, so the homeostasis aspect. And then we've also got conditioning of inhaled air, okay? Humidification, warming, and filtrating, or filtering. Any particles or organisms that come in, anything that's not supposed to be there, our body, our upper respiratory system, and even farther down, that's secondary, I guess tertiary job, is to remove all of that waste, the stuff that's not supposed to be there. And then finally, we've got our smell, our speech, fluid balance, and also temperature control. So those are all very, very important things that the respiratory system does. All right, so with this this little chart here, this is a pretty important chart here. What is this illustrating? Supply and demand. You know, you can go back to your economics or I don't know, whatever, business math or whatever you had to take. Supply and demand is pretty important. If I don't have something, I can't, I can't use it. The more the body, well, what are some things that would affect the body's demand for oxygen? Activity, fever, infectious processes, that kind of comes along with our fever. Our pain, yeah, absolutely, pain. Age, how would age affect it? Okay, so if a patient is older, what's going to happen to their oxygen demand? It's going to go up. And, you know, it will just on a normal, healthy older adult, but also what do older adults typically have? You know, there's things that start to happen. You know, they're have the chronic infections. What else goes on structurally with an older adult? Muscle loss, fatigue, weakness. All these things that we've talked about before are very, very important to understand. With an older adult, they're going to have added issues. Sure. Oh, well, here we go. Alright, so as our body demands more oxygen, we have to do something to bring in more, right? Our lungs, our heart, our blood vessels have to work harder to bring in more oxygen, okay? Or at least more efficiently to use the oxygen that we are bringing in. Alright, so if I have a patient in respiratory distress, what am I going to see? If I have an increased demand for oxygen, how is my body going to react to that, to increase the supply? Increase respirations. What else? Accessory muscles, okay. Yeah, it's going to work harder to bring in more air. Alright, what else? Okay, nasal flaring. Increased heart rate, increased blood pressure. Absolutely. Altered mental status, that's going to be an effect of the lack of demand, right? It's not going to be your normal body process for bringing in more, but the altered mental status could be a result of the decreased supply. Okay, any others? Okay, tripod position. So yeah, the body's going to do some natural things that try to compensate, right? Tripod position. What else? Okay, first, and some of these we have to kind of teach a little bit. You know, just as a general rule though, somebody's going to kind of go down to their knees if they can't breathe, right? So that's more of a natural thing. Now, pursed lip breathing, we kind of have to teach that a little more. We have to breathe them, teach them. In through the nose, out through the mouth, pursed lips. Okay, what does that help to do? Increased oxygen in, and also what else does it do? It helps to blow off more CO2 as well. Okay, so yeah, those are going to be our other abnormal effects, right? If we have a patient in respiratory distress, cyanosis, pallor, what else? So we've talked about the increased muscular effort. So, you've got your retractions, you've got increased respiratory muscle use. What else would you see on a patient that's in respiratory distress? Okay, O2 sats are probably going to fall. Absolutely. What else? Cat refill may become sluggish. Yeah. What else? Okay. Now, yeah, in a chronic situation, you're going to have clubbing of the fingers. Sure. Now, you've got to make sure you distinguish between the acute versus the chronic. They may still have the same. A chronic patient may have acute distress, but those chronic signs are going to be your clubbing. What else? Barrel chest. Okay. Yeah, thinning of the extremities. Any others? From a chronic standpoint. And think back to the COPD section. You've got the barrel chest. What's that going to be a sign of? Which part of the COPD? Emphysema aspect. Okay, that's the pink puffer. And then what's the alternative? The chronic bronchitis is the other aspect of it. What's that going to show up as? The blue bloater. Okay, the cyanosis, the pallor. All right. So we kind of hit a couple different things there, but all right, some of the other alterations, we've talked about some of these, but you've got the level of activity, okay? You increase activity, you're going to increase demand, right? Current and past medical history. What are some things in a current or past medical history that could affect a patient's respiratory status? Smoking, absolutely, probably number one, right? What else? Environmental factors, okay? What's that? Okay. Environmental factors. What it also in line with those environmental factors? Travel, job, occupational history, big time. Okay. Any others? Past and current medical history. Trauma. Okay. What type of traumas would we look for? Okay. A blunt force trauma. If they have just or previously had blunt force trauma to the chest cavity, what could that do? Break a rib. Yeah. There you go. So all these things that could currently do it, but okay, if I had blunt force trauma that altered the structure of my chest cavity, there's a lot of, especially rib fractures, they just kind of stabilize sometimes. They're not necessarily going to go in and do a surgery unless it's causing some kind of secondary action, pneumothorax or something like that. They may let that kind of grow and heal. That could alter what? Chest wall expansion. Absolutely. All right, so those are all very, very good things. What about, let's say a patient has renal failure. Would that be something that could alter our respiratory function? Okay. Yeah, it could alter our acid-base balance, right? And that's just an example. Our body, our respiratory system, is going to have an alteration based off of that to what? Compensate. All right, so that's, don't just kind of keep it in this respiratory realm of, okay, it's respiratory and it can only be respiratory. Well, it could be, as we talked about extensively, the metabolic system could alter the respiratory system because it has to compensate for that. All right, we talked about age. We've got nutritional status. Talked about cigarettes, tobacco smoke, environmental conditions, occupation, infection. We've got all types of respiratory infections and non-respiratory infections that could alter the respiratory system. With fever, we talked about that. Drug use, prescribed or illegal. What are some drugs that we don't prescribe, but we give with an order? Morphine, narcotics. How are they going to alter the respiratory system? They're depressants. Okay, so they depress the respiratory system. They depress the central nervous system. They slow everything down. Okay, family history, genetic risk, and then also the injury we talked about with the trauma. All right, be familiar with these adventitious lung sounds. Know that some of these conditions over here, we've got asbestos, atelectasis, interstitial fibrosis, bronchitis, pneumonia, chronic pulmonary diseases. Those can show crackles, rails, okay? Pneumonia. Pneumonia, we've got crackles up here, but we've also got our crackles. It could also produce, what else? Okay, wheezes. Okay, and it doesn't even have that one on here, but it could definitely do wheezes. How would a patient with pneumonia, or why would a patient with pneumonia develop wheezes? Inflammation of the bronchioles. There you go. Now, the pneumonia is going to have the edema inside the lung, but we're going to have more secretions, right? We're going to have more secretions there in the lower airways, but also in these upper airways. Okay. The wheeze itself is going to be evident of some type of obstruction, or not necessarily obstruction of occlusion, but yeah, there's something in those lower airways causing that high-pitched, not really a squeal, but high-pitched wheeze. Okay. Think of those big bronchioles, main stem bronchi. Those are the ones that you're looking for with the rails. All right. Think of the different sounds. I'm not a big music guy, but you got a big tube, maybe one of these big construction sites. You put something in a big tube and whip wind through it, it's going to make a big, kind of a deeper, louder sound, right? A small tube, like a straw, it's going to make more of a whistly sound if you put it in the wind. I guess. I don't know. It's the best example I can come up with. But just think the differences between those two. All right. Know your normal. A little off there, but know your normals on your PaO2. You need to know 80 to 100. Okay. Could we have more than 100 on our PaO2? And what would that be an indicator of? Oxygen toxicity. And it doesn't even have to be altered, or above the 100. But even if you're on that higher side, that's an indicator, hey, we're giving a pretty high concentration of oxygen. Remember, the PaO2 is not a percentage. Okay? That's an actual oxygen measurement inside the arterial blood. Now, the SaO2, is that going to be above 100? No, because that is a percentage. 95 to 100% is our SaO2. Okay? And then we've gone quite a bit in depth on our pH, 7.35 to 7.45. The CO2, 45 to 35. Remember, the 45 is going to be on the acidic side. The bicarb, 21 to 28. Those are the numbers we're going to use. We've used them consistently here, but also on the test. So if you read literature, and you will, a lot of the literature has different stuff on this bicarb. 21 to 28 is what we're using here and on the test. Okay, that's what I've seen in the NCLEX books now. Okay, so 21 to 28. If something changes, we'll let you know. All right, know the grid. Okay, know how to interpret these changes. Be very familiar with that. Okay, we did a whole slide presentation on that. I'm not going to really go into that too much. What's the first thing you have to do, though, when you're interpreting? Look at your pH. Okay, if you don't do anything else, look at that pH and figure out, okay, is it normal, or is it acidosis, or is it alkalosis? Okay, that's going to be your first step. And even if it's normal, kind of figure out which side of of the range it's going to be on. Okay, and then which one caused that pH to move? That's an important point. I want you to kind of make sure I kind of hit home. The pH is not causing the CO2 or the bicarb to move, unless it's trying to compensate. The pH is caused, the movement is caused by either a respiratory problem with the CO2 or a bicarb problem with the metabolic system. Okay? So you just have to line them up, figure out where that issue is. All right. Now, we talk about this. Know your clinical manifestations of respiratory distress. A lot of these scenarios are going to involve these signs and symptoms. Now, what do you do about it? Okay, dyspnea, nasal flaring, use of accessory muscles to breathe, pursed lip or diaphragmatic breathing, decreased endurance, skin, mucous membrane changes, including pallor and cyanosis, changes in mental status, including irritability and restlessness. These are signs that a patient is struggling to breathe. They are not meeting that demand for oxygen. Okay? When we get down to the bottom here, change in mental status, irritability, and some restlessness, what is that an indicator of? Okay, respiratory distress, but specifically what part of respiratory distress? Hypoxia where? Cerebral hypoxia. Okay, cerebral hypoxia. The brain isn't getting enough oxygen. So we've got an alteration in oxygenation at the brain. Okay? Cerebral arteries are not adequately oxygenated. All right, now we got a patient that comes in for a thoracentesis. Probably is already there, but they have a thoracentesis done, and you start to see these complications. Pain on the affected side that's worse at the end of inhalation than at the end of exhalation. Rapid heart rate, rapid shallow respirations, feeling of air hunger, prominence of the affected side that does not move in and out with respiratory effort, trachea slanted more to the unaffected side than the center of the neck, new onset nagging cough, and cyanosis. What's going on here? Okay, pneumothorax. The thoracentesis was supposed to go into the pleural space. May have gone in the pleural space, may not. Regardless, we have a collapsed lung. Okay, air hunger. Yeah, you're hungry for air. You are struggling to breathe. You can't get in enough air. So these patients are in respiratory distress. They just, regardless of how much they breathe in, they don't feel like they get enough. All right, complications. This has caused now a pneumothorax. All right. Be familiar with the signs and symptoms of a pneumothorax. Okay. All right, so a nasal cannula. We can give a nasal cannula if a patient needs 1 to 6 liters of oxygen. If a patient needs 7 liters of oxygen, what do I have to do? Move them over to a face mask. Okay. All right. I've moved them over to a face mask. The patient's oxygen level goes down. Let's say the oxygen level is now 4. Okay. So I take that face mask and I bump it down. Is that right? No. What do I have to have that face mask setting? It's got to be at least 5. I've got to turn it up to 5 or greater. But what am I doing? Yeah, I'm not giving them any oxygen. I'm giving them air. There's probably some oxygen in that air, but I'm not helping them out any. You'll start seeing SATs drop if that's the case. Okay, so a face mask has to be at least 5. O2 or nasal cannula, not going to go up above 6. Now, the nasal cannula, you're still giving them oxygen. You're still giving them 6 liters. You're just not giving them any more than that. Okay. Let's see here. All right, now I've got a patient with a trach. starts showing signs of respiratory distress, I listen, I auscultate, and I hear some congestion, some rails going on, okay? What do I need to do? Suction. How am I going to suction this patient? Okay. Yeah, that's pretty important there. You're going to suction when? As you withdraw the catheter, okay? All right, and what else? Okay, intermittently on the way out using a circular motion. And I'll probably show you that a little more tomorrow in lab, but intermittently on the way out. What would I want to do before I even get to that point, though, when I'm suctioning on the way out? Okay, first I need to assess the patient, okay? We've assessed now, and we've listened, and everything's good. Sats are not real good, but they're probably not going to be if we're having a suction too much. So what do? Hyperoxygenate, okay? How am I going to hyperoxygenate the patient? Well, usually what we'll do is we'll take an ambu bag with 100% O2, be an ambu bag, and we're going to suction. If it's trach, we're just going to connect it to the trach side. Hyperoxygenate, usually 2 to 3 good puffs, okay? And we withdraw, got to be quick with it, right? All right, we're going to suction, insert the catheter, and suction on the way out, okay, intermittently. What would be some things that would alter that oxygenation ability? What are some things that are going to affect that patient's ability to, or well, what are some things that are going to cause that patient to reduce their oxygen level? Okay, a mucus plug. Okay, I'm talking about during that suctioning process. What could happen? Okay, if I suction too long, what's my time limit here? 10 to 15 seconds, so 15 seconds being the absolute max. And then I do what? As soon as that 15 seconds is up, I've got my catheter out, what am I going to do? I'm going to re-oxygenate, okay? Get the oxygen back onto them. Don't let them go more than 15 seconds as the absolute max, okay? But 10 to 15 seconds is your window. Those are your two numbers there, 10 to 15 seconds. 15 seconds being the absolute max, okay? All right, what could happen if I suction on the way in? Okay, tissue damage, okay? Also I could cause the patient to desat, okay? I could hypooxygenate, deoxygenate the patient, yeah. But the big thing, you don't want to suction on the way in because you could cause that tissue damage and swelling, all right? Okay, yeah, 3 times. 3 times is all you want to do in one suctioning time frame. Okay, so you hyperoxygenate, you suction on the way out, you reoxygenate. Okay, so kind of stabilize. You can suction again, second time, and then the third time is it. Okay, after that you need to give them, a break. Okay, what are some other things that or could be complications of suctioning in the tracheal suctioning? Okay. Bleeding, yeah, I mean, if you cause enough tissue damage, you could do that. Hopefully you're not going to do that, but I could see that. What else, though? What are the big ones, though? Infection, because what are we doing? We're introducing a foreign thing straight to the airway, right? And then we're putting air behind it and really giving it a vehicle to go. Okay, so infection's a big one. Okay, hypoxia, absolutely, big time. Okay, what else? Tissue damage. All right, and what else? There's one more. Could dry out. Okay, that's probably going to be more of a product of the air that we're getting. We're not humidifying properly. Because usually if we're suctioning, we've got them nasty wet. We're trying to keep them from getting too bad. Vagal response. okay, or vagal stimulation, including bronchospasm and cardiac dysrhythmias as well. But the hypoxia is going to be big, the tissue damage is going to be big, and the infection is going to be big. And then that vagal response is, that really shows some signs. All right. So what are we going to do to try to prevent infection? What are the precautions? Sterile technique. Okay, sterile technique anytime you're dealing with a trach. All right. So there's the complications there. We've also got some of the causes of hypoxia, including ineffective oxygenation before, during, or after suctioning. Use of a catheter is too large for the artificial airway. Prolonged suctioning time. Excessive suctioning pressure. You may know what the suctioning pressure needs to be. Yeah. 80 to 120 is going to be your optimal range there. You definitely don't want to go above the 120. That's going to be the big one. Less than 80 is probably not going to get the job done, so you're wasting your time. But 80 to 120 is kind of what they go with. At least that's what the book said. All right. Also, suctioning during catheter insertion can cause hypoxia. Okay, don't do that. And also too frequent suctioning. So we do it 3 times. We probably need to give them 30 minutes to an hour. Now here's the thing: if a patient's in respiratory distress and they cannot breathe, you got to do what you got to do. Okay. In that case, if a patient is in that bad of distress, it's probably time to think about changing out the actual trach. Okay. Well, not larger. What you would do is you would take that one out and see. A lot of times you would have plugs and things that will attach to it, obstruct, and you just can't suction it out effectively. So in that case, same size, what you want. You're right there, ready. Take the old one out, put a new one in, using sterile technique. Sometimes that's all it needs. Alright, trach care, we're going to go through that tomorrow. We're going to go through that in depth tomorrow. But it's extremely important for the patient to have trach care because it's going to reduce secretions that collect in the trach tube, maintain patency of the airway, prevent infection, and also promote effective wound healing at the trach site. Now, how are we going to say the patient, or not the patient, say the physician has decided that we're going to wean the trach? What's the process or the steps that we're going to take to remove that trach? Now, this is all by order, and they're going to kind of walk you through it. But okay, deflate the cuff if it's not been deflated, and usually the cuff is only going to be inflated while the patient's on a ventilator. That's their typical. Once the patient comes off the ventilator, they'll usually deflate the cuff. But if it hasn't been deflated, we got to make sure that cuff is deflated first. All right, what else? Okay, they're going to start to move down the trach size. Let it grow up a little bit on its own. Some of them go down farther. Some of them leave it more open. It kind of depends on physician preference. All right, and what's the third criteria? Capping. Okay, capping is going to be an absolute. And how long do we have to cap for? 24 hours without any added intervention. Okay, so the patient can't. If the patient can't maintain secretions, they can't cough up secretions, and they suddenly start to struggle, and we have to remove that cap, it's not going to happen in 24 hours. Okay, we've got to wait until we can start over and recap. Okay. Now, with that being said, if you are taking care of a trach patient and they are in absolute distress and they've got a cap on, what can you do? You can remove it. That's still an open airway. Well, it's a closed airway if it's got a cap on it, but it is still an available airway. Okay, that's why we don't want to take it out until we know they can maintain those secretions. adequately oxygenate for 24 hours. Okay. Okay. So now they've maintained it for 24 hours. Everything's good. What are we going to do? Okay, we remove it, and then gauze and tape dressing. Okay, not occlusive, just a gauze and tape dressing. All it's gonna do. There's all that. Dry gauze, tape dressing over the stoma. All right, now here's a look at the upper respiratory system alterations, kind of all condensed into one page, but more in a condensed form. Okay. The key here, most of these treatments are all going to be the same, right? It's an upper airway issue. We're going to kind of treat it the same way. Depends on what is causing the infection or the inflammation. So rhinitis is inflammation of the nasal mucosa. Manifestations are going to be headache, nasal irrigation, sneezing, nasal congestion, and rhinorrhea. Treatments depends on what the source is, but if it's bacterial, we're going to do antibiotics, antihistamines, decongestants, singulair, antipyretics, and then relief of symptoms. Okay. All right. Sinusitis instead is the sinus mucosa, inflammation of the sinus mucosa, and manifestations: nasal swelling and congestion, headache, facial pressure, pain. Treatment's going to be pretty similar. Antibiotics if it's bacterial, analgesics, decongestants, steam humidification, hot and wet packs over the sinus area, and nasal saline irrigations. Also, we want to increase fluids. Why would we want to increase fluids? Thin the secretions. Helps get them up, right? And then finally, we've got our FEST procedure would be a surgical intervention, depending on, usually they're not going to start with a FEST procedure. The patient has recurring sinus infection and they just can't get over it. You might remember what the FEST procedure was? Yeah, and they're going to use what? They're going to take a big long needle, shoot it up into the sinuses, and then they're going to try to drain off all of that fluid that's in the sinus. So, what is our post-op for that? Well, what do we need to monitor post-op for a FEST procedure? Bleeding, okay. And what would be a good sign of our bleeding? Okay, constant swallowing. We're looking for constant swallowing because it could be bleeding, but it could also be what else? That's another big one. We're right there with these sinuses. We're right there by the cerebral spinal canal. We got to watch for it. Okay. So how would we determine if we have CSF? Okay. The patient's constantly swallowing. We're going to look at the drainage for color. What's the color going to be? Clear. And if it's mixed with blood, you're going to have a halo. Okay. It's going to be kind of a yellowish halo, circular halo. All right. What else? So it's clear. But what other types of secretions are clear? Just normal nasal secretions, saliva. Good. So how do we determine whether that is saliva or if it's CSF? Yeah, they've got CSF strips. But what is going to be tested in that CSF? Anybody remember? Not protein. Enzyme. It's going to be glucose. Oh, you didn't say it loud enough. Glucose. That's what we want to test for. Glucose. All right. When else might you want to test for CSF? What other scenario? Okay. So they've had a trauma. All right. They fell off a building. They had a wreck. Okay. Any type of trauma, specifically involving what? The head, the spine. Yeah, anything closely related to the CSF or close in proximity to the CSF. All right, so what are we looking for? same thing, right? Any type of clear drainage that's coming from the ears, the nose, they're spitting a lot, okay? They have maybe a spinal wound that we've got a dressing on, maybe even an incision. Maybe it's a patient that went in for a back surgery or a neck surgery, and we start having a lot of clear drainage coming out. Oh, let's look at that dressing with a halo. Okay, let's look to see as it mixes with that blood, what happens. Got that halo. So we're going to test it with our glucose strip. Okay. I don't know about the silk pillow. It's possible. You're going to see those halos, and usually it's when it kind of mixes in with blood. That's when you'll typically see the halo. But it could be a silk pillow test too. All right, good. Does it have a what? I don't think it does. It could. It may smell sweet. It's high in glucose, so I don't know. Okay, that sounds plausible. I don't know. I haven't read that, but yeah. As I lay on the silk pillowcase, they start smelling bananas. No, I don't know about that, but that sounds plausible. We can do some more research on that, but okay. It makes sense. Yeah. Yeah. It makes sense. That may be an added diagnostic tool that you use there. All right. No, hey, we need to look it up. That's a pretty good indicator. Don't rule it out though if it doesn't smell like bananas. How about that? Don't use that as a definitive, just in case. But that's, if you do see clear fluid that smells like bananas, you may do some added investigation. All right. Well, let's move on. We've got pharyngitis, or our sore throat. Okay, inflammation of the pharyngeal mucosa, often occurring with sinusitis and pharyngitis. Okay, the cause, it's bacterial. Commonly, the bacterial is going to be strep throat, but it could be a viral cause or just from other irritants. Okay, manifestations, obviously a sore throat, or dryness and pain, difficulty swallowing, fever. If it's bacterial, it's probably going to be a pretty high fever. Tonsil enlargement and redness is likely, and it also may cause a peritonsillar abscess and tonsillitis. Treatments, just like all these others. Bacterial is going to give antibiotics. If it's viral, we're pretty much managing the symptoms. Okay, antipyretics for our fever, analgesics for pain, and then also just symptom management. All right, influenza. Highly contagious acute viral respiratory infection. Vaccination is advisable for prevention. Manifestations include our aches, our fevers, our chills. Okay? They just feel weak, they feel tired, they just feel like they can't get out of bed. Also, anorexia, they'll feel like eating. And then again, the sore throat, cough, and watery nasal discharge. And this could occur for 2 to 3 weeks after the actual, all the other symptoms go away. Okay. Treatments. Now here's a big one. Tamiflu and Relenza have to be within 24 hours of the onset of symptoms. If not, it won't do a whole lot of good. Antipyretics, analgesics, and antihistamines. Again, we're managing symptoms. And then our final upper respiratory system alteration, laryngitis. Laryngitis is inflammation of the mucosa of the larynx and possible vocal cord swelling. This could also be a product of all of the others that we've talked about. Okay. Manifestations include acute hoarseness, dry cough, difficulty swallowing, and temporary voice loss, also known as aphonia. Treatments: relief of inflammation, including voice rest, steam inhalation, increased fluid intake, throat lozenges, antibiotics, and bronchodilators. Okay. What's the, all of these we've talked about. Take out the influenza. That's kind of a different one. But all these others, we've got laryngitis, pharyngitis, sinusitis, and rhinitis. What are the common things? How would we treat all of these conditions? Yeah, antibiotics if we need them. Okay, if it's bacterial. Treating the symptoms. What was that? Anti-inflammatories. What is the thing that we're really going to want to watch for in a patient that's worsening? Breathing. Okay, airway and breathing. These are all things that are going to affect sinusitis. Maybe not quite as much, but if we've got nasal swelling, what could that do? Could impede the airway in some way. Okay, pharyngitis especially, and also the laryngitis. They could significantly impact the airway. That's what we kind of need to watch for. Now, this is not just your typical, I got a sore throat, but it could lead to worsening of symptoms. Particularly, what's tonsillitis, okay? So what could that do? You could definitely impede the airway with tonsillitis, okay? It's more of the complications of these. Croup. What's croup? Yeah, the barking cough. It could go along here with the laryngitis. It could also go along with the pharyngitis. Okay. Epiglottitis. We haven't got that one in there. But epiglottitis. It's those things that can swell. Inflammation causes swelling, right? So if we have inflammation along the airway, it could cause airway impairment. That's what you need to look for. When the symptoms, we got these normal symptoms, but now they've moved into a different type of thing. Now we've got upper airway type of obstruction. All right. If it's bacterial, it's commonly going to be a strep infection. Now, it could be any of these. Kids are probably more common to get the actual strep throat infection, obviously. I mean, those are the ones that typically have it. So, I guess it depends on who you're talking about. With kids, pharyngitis is probably most likely going to be a strep throat infection. If it's bacterial, it's most commonly strep. That's probably as far as I want to go and differentiate. But if it is bacterial, it's most commonly a strep throat or streptococcus is just the cough. Okay. All right. Yeah. That's as far as I want to go on that one. All right. Well, okay. In influenza, we kind of skipped influenza. Influenza, well, we've got the fever. We got to get the fever down, right? What else do we need to make sure of? Influenza. Hydration. Okay. Hydration. They're weak. Usually, they kind of have the sore throat going along with it. They don't feel like eating. They don't feel like doing anything. Okay. So we've got to make sure that they are maintaining their fluid. Dehydration is going to be the big issue. If they say, they say stomach flu, it's nothing related to influenza. That's just a general GI virus or some type of GI irritation. That is not going to be related to influenza. Influenza is only going to produce respiratory symptoms, okay? Or respiratory and then the basic weakness and fever and chills and all that. But it's going to be that related to that versus you're not going to have GI upset with influenza. Now, you may have influenza and something else along with it, but yeah. When they say stomach flu, they're not talking about influenza. All right. Now let's move into facial trauma. Again, airways number one. Okay, stridor, shortness of breath, dyspnea, anxiety, restlessness, hypoxia, hypercarbia, decreased oxygen saturation, cyanosis, and loss of consciousness. These are the signs you want to absolutely 100% look for first, because these could indicate airway compromise. Okay? Alright, so number one, facial trauma. Okay? It's still looking at CO2. It's just the way they measure it. It's still, you're looking for high CO2, low oxygen. That's it. Alright, so those are your manifestations that would indicate we have respiratory compromise when dealing with facial trauma. Okay? Next, epistaxis. Epistaxis. Okay? What's our treatment going to be if we have a patient that has, well, for one, what is this? Nosebleed. Okay? If we have a patient with a nosebleed, what is our treatment? Stop the bleeding. So how do we do that? Okay? Do we want to do that? No, because all the blood just runs down. All right? So we lean them forward and apply pressure. Okay? And I've seen under the mustache, that helps too some, but regardless, you want them to lean forward and apply pressure. Okay? I think it's got to be an occlusive mustache. So hopefully your mustache is not occlusive. But epistaxis, we're going to position the patient upright, leaning forward, prevent blood moving to the stomach and possible aspiration. Apply lateral pressure to the nose for 10 minutes. Apply cool, cold compresses if possible. Encourage the patient not to blow their nose for 24 hours. Okay. Assess for respiratory stress, tolerance, and packing the tubes. Commonly, well, that's not always, but if the patient is struggling to breathe and they have packing, what are you going to do? Yeah, remove the packing. Now, just on a side note, make sure they're really struggling to breathe before you take out the packing. Don't just yank the packing out unless they are truly struggling to breathe, or you'll have a surgeon that's a little bit mad at you. But if you provide respiration and the patient's struggling to breathe, you can take out the packing. Usually that's going to be done by what? They usually have some type of string or some kind of thing that you can quickly remove that packing. Let's see here. Our laryngectomy. Okay? Laryngectomy is when we have some issue, usually cancer, usually a tumor with cancer, on the speech structures. Okay? Laryngectomy means they have removed all of the structures that are associated with speech. They no longer have that as a possibility for use. Our post-op care is going to be similar to that of a tracheostomy. Airway maintenance and ventilation, wound flap and reconstructive tissue care, monitor for hemorrhage, wound breakdown, pain management, nutrition, and then we start communication. It's the same thing with the trach. We've got to consider the trach of the communication as well. One thing the laryngectomy is not going to cause that we would have to kind of monitor with the trach is going to be the risk for aspiration. we've diminished a lot of that aspiration risk. Now, unless we introduce something, okay? But from a swallowing standpoint, basically the tubes are no longer closed now, okay? The esophagus and the airway are no longer connected, or not close. They're not connected, but they're no longer close to where they would be connected from swallowing. Much less risk for aspiration. That's the key there. All right. Well, let's take a break then. All right, so we're going to start back up with pulmonary embolism. Okay, pulmonary embolism. Why is pulmonary embolism a problem? Yeah, it can kill you. But what causes the death there, or the potential? There you go. It's blocking pulmonary circulation, correct? All right. So what are some signs that we would have a patient that may indicate that the patient is suffering from a pulmonary embolism? Chest pain, okay. Is there a specific characteristic with the chest pain? Yeah, it's an acute, okay. Acute, what else? Okay, sudden onset, one side, absolutely. Okay, it increases when? Yeah, you'll have increased respiratory rate, but what about that chest pain? There's one other aspect of the chest pain. It happens, the pain gets worse when you breathe deeply. Also, when you do what else? Cough, eat, bend over or stoop. Okay. Pain will get worse with exertion, but won't go away when you rest. Okay. All right. What else? What other kind of? We had the increased respiratory rate. What else? Increased heart rate. Okay. Okay. Patient may get a sense of impending doom. That's correct. There's some others though. Calf pain. Usually the calf pain is going to kind of precipitate it, right? But yeah, I mean the calf pain, it indicates what? The deep vein thrombosis, which is usually the best or well, not the best it's the most likely source of the pulmonary embolism. Okay. All right. So let's look at this. All right. So dyspnea, so I can't breathe. It gets worse with exertion, but does not get better. Chest pain may become worse when you breathe deeply. Cough, eat, bend, or stoop. Pain will get worse with exertion, but will not go away with rest. Cough may produce bloody or blood-streaked sputum. Also, the leg pain, swelling, or both, usually in the calf. That's a really good indicator of the deep vein thrombosis. Okay. Most common source of the pulmonary embolism. Clammy or discolored skin, including cyanosis. Excessive sweating, rapid or irregular heartbeat, and lightheadedness or dizziness. All right, so what are we going to do? And this was one of the things we had a question about last week. All right, what are you going to do first for a patient that is suffering from a pulmonary embolism? Well, at this point, you may not know that it's a pulmonary embolism, but they have these manifestations. What are you going to do? Oxygen. Okay, number one, oxygen. What else? High Fowlers. High Fowlers. The positioning that we're going to go with for a pulmonary embolism, high Fowlers. Just sit them up. Don't worry about turning them. And I've heard what you meant to do. We're not going to do any of that. We're just going to sit them up. High Fowlers. Okay? Make it a little easier anyway. Oxygen, high Fowlers. What else? Now remember, the oxygen's got to be as ordered. Okay? So you kind of have two different pathways here. If they've got, I would even say, let's sit them up and get some oxygen. Okay? If they don't have oxygen ordered, what would you do? Sit them up. Yeah. Now, from a test standpoint, here's real life. You're going to give them some oxygen, get an order for oxygen, right? From a test standpoint, you sit them up, and would you want to run to call the physician? What would you do? You stay with the patient and call or send somebody else to get an order for oxygen. Okay? So from a test standpoint, you don't leave the patient's bedside. You sit them up and await an order if they don't have an oxygen order. Practical, you get some oxygen on them and get an order for it. Okay? But somebody else needs to leave the bedside to go get the oxygen. All right? Get the oxygen order. All right. So, oxygen, positioning in high Fowlers. From a test standpoint, you got to get an order for the oxygen. You can't give oxygen unless it's ordered. Okay. Well, it depends. Yeah, if they're now look, if you need an ambu bag, you just free for it. I mean, that's not an administration of oxygen. An ambu bag is. Yeah, you could probably do that. It's not going to do a lot of good without the oxygen aspect, though. All right, buddy. We don't want to bog it down too much. Oxygen, high Fowlers. Make sure you have the oxygen ordered. Okay. Oxygen, high Fowlers. Apply telemetry monitoring equipment as ordered and available. Okay, but again, telemetry you got to have an order for. Obtain IV access if not already available. But again, you got to have an order. Ambu bag, big blue bag that you squeeze to provide respiration. So whether it could have a mask in it, yeah, CPR. Yeah, either way, it's just the bag that's compressed through the mask or the straight connected. All right, so obtain IV access, monitor oxygenation via continuous pulse ox. Now, pulse ox, you can get a pulse ox on them without necessarily an order. Now, continuously, you need an order for it, but you can put a pulse ox probe on a patient and monitor it. Okay. Assess respiratory status at least every 30 minutes via auscultation, respiratory rate and rhythm, and also monitor circulation. You also want to assess cardiac status, including blood pressure, pulse rate, and quality, ECG, and neck vein distension. You can do a set of vitals without an order too, right? I mean, you know, patient starts going down, you sit them up, put a pulse ox probe on them, and do vital signs without getting a doctor's order for those things. But if you've got oxygen ordered, you better give it. And then ensure immediate implementation of prescribed chest imaging in labs. Again, as the doctor orders those, you need to make sure that they're done quickly. Observe the chest for petechiae and also bleeding. Administer anticoagulants as prescribed, and handle the patient gently and implement bleeding precautions. All right. Everybody good with that? Positioning, you're going to sit them up. Well, 85% is going to be, you're still not perfusing the tissues, okay? So, you know, you still got to do something to bring up the oxygen saturation. So if it's administer oxygen as prescribed, whether it's, what other things can we do as nurses that could improve that? Okay? Positioning, turn, cough, deep breathe if that's, if that's possible. but sit them up, okay? Monitor those sats. If they have oxygen ordered, we would administer that. I always consider, hey, let's get these nursing interventions for sure. Probably not going to be toxicity. You're probably going to struggle to get to 96. Here's what we want to get them to a 90, or at least close to a 90. An 85, you're having tissues that are not being perfused. So you want to get as close to 90 as you can. Usually their orders, keep above 89%. Depends, but 85 is a little low. I could see them saying 88, 89, but 85 is down there a little farther than I would expect. Exactly. So y'all were taught 85? And it can be. Well, and now here's probably what the issue is. Because what happens, what triggers a COPD patient to breathe? Is it CO2? Now, on a normal person, yes, CO2. But what's the trigger for a COPD patient? Oxygenation. So what they'll do is you increase the oxygen level too much on a COPD patient, they lose their drive to breathe because they just have the oxygen and they become reliant on that oxygen. Yeah. Us, a normal healthy patient, the CO2, when those CO2 levels rise, what does that tell us to do? Our brain tells us to breathe faster so that we can blow it off. Right? So our CO2 is our trigger in a normal healthy patient. A COPD patient, they get rid of that CO2 drive because their CO2 levels are constantly high. Now their only drive is oxygenation. If the tissues are oxygenated, we're good. We're not even going to have, they almost get lazy. We're not going to breathe any faster because we're not worried about CO2. All we're worried about is oxygen. So that may be a little different. It is very, very difficult to get a COPD patient off of the oxygen because they lost that trigger. Yeah, that's an excellent, because, the emphysema aspect of it. What are we doing with emphysema? We've got, what's the problem with emphysema? Okay. Well, specifically, maybe bronchus, but more importantly, what's destroyed? The alveoli. And that's where that gas exchange, the oxygen coming in and CO2 coming out. And the more oxygen we bring in, like you said, the more the tissues are going to burn off CO2, right? As they use the oxygen, it burns off CO2. CO2 has to be removed. Yes. You have to basically do low levels and try to get it up as much as you can, using the positioning, using the breathing techniques. That's the whole, the pink puffer, that's the CO2 trapping, air trapping aspect of it. You're bringing in air with emphysema at that part of the CO2. You're bringing in plenty of air. Problem is you can't use the oxygen and you can't get rid of the CO2. So it all just kind of traps and sits in there. Now, you get to a certain point, and these patients are not, you can't, no matter what you do, you just can't get them up to a certain level. And that is their minimum. so I guess it depends on the circumstance. All right. So this is what we're going to do with our pulmonary embolism. Okay, we've done our initial emergent nursing management. Okay, now this is more from a medical standpoint, and kind of using those medical orders. But IV morphine, compression stockings, more of a preventative measure, prevent the clotting, prevent the DVTs from forming, anticoagulants, heparin bolus drip, heparin bolus, and also the drips. But we also have the Lovenox. What's Lovenox? It's going to be the sub-Q. Yeah, it's going to be the sub-Q. We would give that more on a maintenance type basis. Coumadin, regardless, we're just trying to prevent more clots from forming and the potential for greater pulmonary embolism risk. All right, the TPA therapy or thrombolytic therapy, basically we're busting up the clots that are already there. Okay, we're trying to bust up what already has formed, but what do we have to do in conjunction with the thrombolytic therapy? Make sure they are following the anticoagulant protocols as well. If we break up the clots, what happens? Now they're traveling, so we are almost creating, we're creating emboli. So we do the anticoagulants that help to break down the clots that have already formed and have been broken up. Does that make sense? You got to have the anticoagulant therapy in conjunction with the thrombolytic therapy. If not, you just have traveling clots. Well, not if they're having respiratory distress as a result of it. Yeah, I mean, at that point, we've got to break it down as much as we possibly can. It's causing, it's obstructing pulmonary circulation at that point. So we have to do something to remove that obstruction. Okay, so let's go back. All right, so a patient has a pulmonary embolism and it's obstructing pulmonary circulation. Well, these clot busters, they're going to break them up pretty good, but now we have it in circulation versus there. So what we're doing is we are busting them up, but we're also doing the anticoagulants to thin them. Okay, so thin out those clots where they're not going to obstruct anything. They've also got the filters. Okay, you've got the embolectomy. Also, the embolectomy is when they actually go in and remove it. But the filters, the greenfield filter, they take a filter, they put it just below the heart at the inferior vena cava, and it filters all the blood out. It prevents those clots from being able to move into pulmonary circulation. Does that make sense? Any other questions so far? They're going to put a filter in in the inferior vena cava, and it filters clots that are traveling up to the heart and pulmonary circulation. So it catches those big clots, so they can't pass through into the pulmonary circulation where they can be damaged. Now, with those, they also have to be in conjunction with anticoagulants too, so you don't just have a bunch of clots building up at the filter. But that's going to be what that's designed for. It's just, there's even clips as well that will actually clip it off to where the large clots can't travel through as well. But the goal is to prevent those clots from traveling into pulmonary circulation, where they can prevent not respiration, but oxygenation. Okay. The ways to prevent, and this is a big part of the nursing management of pulmonary embolism. We want to prevent it as much as possible. We do this with active leg exercises, early ambulation, encouraging the patients to get up and move, No sitting or lying for long periods of time. If they're on a trip, patient that's at increased risk for pulmonary embolism, when they're on a trip, they need to stop at frequent intervals, get up, walk around. Also, pneumatic and elastic compression stockings, and also the compression devices. Very, very important, especially for our patients that are in a hospital setting, because in most cases, they're not getting up as much as they normally would or they need to. Okay? They need to avoid sitting with their legs crossed. We want to teach them signs and symptoms of DVT and also the pulmonary embolism. So these signs over here, you need to make sure that the patient knows these signs. If you start to notice these signs, we need to let somebody know. Okay? The goal is to try to prevent the pulmonary embolism from causing the respiratory issue. All right. Also, low-dose anticoagulant for those undergoing surgery. Additionally, we want to monitor anticoagulant therapy, including during the infusion, we want to do bed rest, vital signs, O2 sats, limit invasive procedures, monitor PT and PTT, and then also monitor for bleeding. Also, we want to provide pain management, anxiety management, and monitor for complications, cardiogenic shock, right ventricular failure, and education. All right, so that's pulmonary embolism. What do you think is going to be the priority for that patient? If the patient is suffering or has a potential for pulmonary embolism, what's your priority interventions? Okay, if they are in an acute distress, sit them up. Okay? Sit them up in half hours. Okay, and then go through and figure out, do your assessments, nursing assessments. Oxygen, if you've got that, it's going to be pretty important too. All right. Pneumonia. Pneumonia is going to be excess fluid inside the lung that results from the inflammatory process. Okay? So, some type of infection, some type of local issue inside the lung that has caused inflammation. And inflammation results in swelling and fluid buildup. So an outside source, an outside thing has come into the lung and caused the inflammation. All right. Now, in contrast, pulmonary edema. Pulmonary edema is a condition caused by excess fluid in the lungs. So it's also excess fluid in the lungs, but the distinguishing characteristic is instead of infection or some kind of foreign substance that causes inflammation, this is caused by more of a systemic issue. Okay? Heart problems, fluid accumulations. So over accumulation of fluid into circulation, circulatory overload. Exposure to certain toxins and medications, trauma to the chest wall, and exercising or living at high elevation. Treatments are going to depend on the source and severity, but it always involves oxygen and medications in most cases. Okay? Not always, in most cases it's going to involve oxygen and medication. Okay? What kind of medications do you think we're going to use for a patient in pulmonary edema? Okay, bronchodilator, diuretics. Diuretics is going to be an important part. Okay? We got to pull that fluid off in some way. Now, there's a third thing. Well, okay, so here's pulmonary edema. This is how the fluid moves out of circulation and into the lung. Okay, let's go. We'll go through this. Okay, pulmonary edema. So these are some of the clinical manifestations you'll see. Sudden acute pulmonary edema symptoms include extreme dyspnea that worsens when lying down, feeling of suffocation or drowning, wheezes, anxiety, restlessness, or a sense of apprehension, cough that produces frothy pink sputum. the frothy sputum is going to occur as that pulmonary edema gets worse. Okay, so it's not a good sign. The chest pain, if the pulmonary edema is caused by heart disease, the patient also may suffer from rapid irregular heartbeat and jugular vein distension. Okay, why would jugular vein distension be for one, it's a sign of circulatory overload, right? We've got too much fluid in circulation. Okay? But as that moves backwards, that whole system is a big circle. So as it puts more pressure, pulmonary edema puts more pressure on the right side, back in circulation. All right. What's going to be the goal for a patient having acute exacerbation or acute pulmonary symptoms of edema? Okay. Airway. Okay. Correct whatever is causing it. First, we're going to do what? What's the first thing we're going to do as a nurse? What are we going to try to do? Elevate the head of the bed. Okay, if they're lying down, laying flat, we need to sit them up. Okay, high Fowlers. Take some of that pressure off. If they have oxygen ordered, we need to give it. Okay, oxygen. Lasix, like you said, medication. That's going to, in most cases, help with the underlying problem. Pull some of that fluid off. Vasodilators, nitros, butamine, milrinone, digoxin. These are all kind of working on that underlying problem, right? Here's kind of the same thing. The administer oxygen as ordered. Head of the bed elevated. Legs dangling. Why would we want to dangle the legs? Okay. It prevents what? It prevents circulatory return, right? It prevents that return of fluid back to the heart. Okay, which would make the problem worse, right? If we take a patient and elevate their legs, what happens? Yeah, but what locally, what happens? We elevate the head of the bed, or the leg. What happens to the leg? The swelling goes down, right? Where's it going? Back up to the heart. Okay. So we want to dangle if the patient's in overload, circulatory overload, and has pulmonary edema. All right, that's the big stuff there. All right, now pleural effusion. Okay. Make sure you know the difference between the pulmonary edema, the pneumonia, the pleural effusion. Pleural effusion is going to be a collection of fluid inside the pleural space, not the lung, but the pleural space. Okay. Usually, it's secondary to other diseases, including heart failure, TB, neoplastic tumors, pulmonary embolism, and also connective tissue disease. Manifestations are going to include the clear, bloody, or purulent sputum. Okay. What if we continue to add more and more and more fluid, regardless of what type of fluid, into that pleural space? Yeah, it could cause a collapse of the lung. Okay. In most cases, that's going to be due to blood buildup in that pleural space, okay, where it actually collapses the lung. If not, most of the time that's really kind of confusing off. So when we've got the excess fluid in the space, if it is blood, and we continue to have hemorrhage into that pleural space, what could happen? Well, you said it a while ago, collapse the lung. What is that called? Well, if it's caused by blood, it's hemothorax. All right, so we have a hemothorax if we have blood building up inside the pleural space. Now remember, what's the pleural space? All right, so that's our lung. Okay, pleural effusion. if we have fluid buildup here, what's that called? Building, right? Depending on the source, but it's either going to be caused by inflammation. Okay, so depends on where the problem is. Okay, now say we had some kind of issue that caused air to enter this little space. Okay, blocking air. The pressure is building up. What could happen? Inside this little space, the lung collapse. Remember, this part, this inner membrane, collapse, right? That's called pneumothorax. So when the air buildup here causes the pressure to be greater in the pleural space than in the actual lung itself, that's when we have a pneumothorax and that collapse happens. Okay. Kind of related to this pneumothorax. What's it called if we have some kind of fracture? It's called the chest wall, the outer chest wall, that allows air to come in. Inspiration. What's that called? Tension in the thorax. Okay. So when the air comes in, tension in the thorax is when we've got some kind of interruption in the chest wall. We breathe in, what are we doing? We're breathing in air through the normal respiratory tract, but we're also breathing in air through this chest wall. Okay? So what happens? Pressure builds up in that pleural space. We can still have collapse, right? And that one's called detention pneumothorax. Okay. If we just have a patient in the field that has a wound like this, so they have some kind of maybe a car wreck, probably the most common car wreck, and they have this type of injury, how can we help to prevent detention pneumothorax? Chest tube, yeah. If we just had a chest tube, we could probably take care of it. We put a dressing over it that does what? Okay, three-sided dressing. So we've got a three-sided dressing here. You take from this side, that side. What happens over here? Allows air to escape. Okay, allows that air to escape as we exhale. Okay, it just allows it to move out. And it prevents that buildup of pressure inside the pleural space. Okay? So, if we did one dressing that has four sides, what happens? Well, we lose that ability for the air to escape. Then you can build up more and more and more in here, and that's what would cause that tension in the thorax. A little less likely than we allow that to air to escape. All right. So here's just kind of a look at that. It's nice, pretty picture. Pleural space was here. Now it's moved over. We got a pretty good size pleural space now, right? With this pneumothorax. Air is now collected here, and we're unable to re-inflate that inner lung. With this one, we've got the pleural or fluid buildup inside the pleural space here, and that's what's called put more pressure on the inner lung and starting to collapse it. Any questions on that? Really had questions on it previously. Hopefully, it's fibrous formations inside that pleural space. But keeping everybody this is the fibrous tissue inside that pleural space. So the pleural effusion in the chest is anything. What are we trying to do? That chest tube. Yeah, we're trying to drain off the fluid. Okay. And that's another point. If we have a chest tube with a pleural effusion patient, it's probably going to be lower. Probably lower here, because it's going to pull that fluid off at the base of the lung. Okay, so it's going to drop. With a pneumothorax, well, it doesn't really matter, but it's probably going to have to catch it up higher. As you can see here, I mean, you're not really trying to hit a small space with a pneumothorax. You're just trying to get anywhere in that chest wall to be able to evacuate that air out of that space. Any other questions? So that's basically what that is. So during inspiration, on the tension pneumothorax, inspiration, air comes in, it's not able to escape. Okay? Pressure compresses blood vessels and blood returns back to the heart, leading to decreased cardiac output. All right, these manifestations. This is what we covered earlier, but you need to know them. You need to be very familiar with pneumothorax and its complications. They all make sense. You know, this is our problem. What are we going to hear? Well, possibly on the tension pneumothorax, you may hear that. But when you're auscultating, you're not going to hear breath sounds in a completely collapsed lung, because the air's not moving into there. I mean, there's just not. There's not much in it. We can't. There's not enough to reinflate that lung. So there's no expansion and contraction. All right. What are we going to see? One side moving, one side not. Okay. Tracheal deviation. Look. Well, okay. For instance, here, the collapse is here. Everything is going to shift over, and I wish they had a midline, because all of this would shift over to the unaffected side. Okay. Due to all this increased pressure here, all that pressure pushes stuff over. So you've got the shift of the trachea, you've got the shift of the heart, you've got the shift of the other lung. I mean, everything's moved over. A mediastinal shift. And it's always to the unaffected side. Okay. So that's another thing you'll see. What else? Well, what are they going to do? They're going to cough, right? Pre-onset nagging cough. Just as a generalized, just a general nursing thing. If a patient just suddenly starts coughing, just a dry, non-productive cough, usually there's something going on. We can kind of figure out what the issue is. Also, they'll have the signs of respiratory distress. We've cut their respiratory, the ventilation system in half, right? They can't bring in half of the air filled with oxygen that they could before. So that's why you're going to have respiratory distress type symptoms. Hemothorax we talked about. The pressure builds up due to excess fluid in the form of blood in the lungs. You got to pull it off. Chest tube system. Kind of go back through this again. What is this section right here? You can see this section right here. What's its job? Drainage collection. Okay, all the drainage, the fluid being pulled off of the pleural space collects inside that first chamber. Okay, so the fluid falls, the air stays up, and moves through here. Now, what's the purpose of the water seal chamber? Yeah, so it pulls the air through, right? but then what does it do? It keeps it from going back. Okay, we could have suction here to an outside source, just our normal suction system, or we could have this closed off and just have the air out to vent. Okay, what is it doing if we don't have artificial suction connected? Atmospheric pressure is what is pulling it through, and gravity. Okay, we got it lower than the chest, right? So gravity's pulling it out, but also atmospheric pressure is being used to re-expand that lung. Now usually, well, it's not probably going to re-expand it, but it helps to keep it expanded. The suction is usually necessary to keep it, or I'm sorry, to re-inflate that lung. Okay? Because what we're doing, we're removing the pressure inside the pleural space by pulling it off. Okay? That allows the pressure inside the lung to become greater than the pressure outside, and allows that to re-expand. Does that make better sense? Okay. So, water seal chamber, its goal is to pull the air through this chamber, through the water, and out. Now, what happens when in this chamber as the air moves through? Well, this one is going to bubble, tidal a little bit. Now, it will move up. You see that all the water goes up and back, depending on throughout that breathing cycle. But the bubbling is how you know the air is being pulled off of the lung. Okay, so it's going to bubble. Now, this third chamber, what is its function? It controls the suction. Yeah, suction control chamber. It controls the suction. Now, what controls the suction? I know this was part of the discrepancy here. What controls the suction chamber and the pressure that's being applied? With this one, it's how much water do we have in this chamber? Okay? How much water do we have in this chamber? Now, what controls how much water we have in that chamber? The doctor's order. And then we act on that doctor's order. So if the doctor says 20 centimeters of water, and this one doesn't have the line, but you can see over here, there's little lines going up through here. We would make sure that there are 20 centimeters of water. You just fill it up to that line. That's how you know that that's where the level is. That's how much suction is there. Well, if that's what the doctor said, that's what we put in it. If the doctor says 15 centimeters of water, we fill this chamber up to the 15 centimeters of water line. Okay? Or we remove however much we need to remove. Okay? Does that make sense? I want to make sure everybody's clear with that. You put the amount of water into this suction control chamber that the physician orders. And that's how we control suction. Okay? How much pressure is being placed on that lung. Alright. Good with that. Alright. The important things that the nurse should do: fill the water cell chamber to the specified level as ordered. Ensure the suction control chamber is filled. Sterile water. That's the same thing. Attach the chest tube to collection chamber intake. Also, recording. You got to make sure you record the output each shift at the very least. You're going to mark on the side how much has been out, basically the time you left. So we've got our chamber here. Here's our drip chamber coming in. This is the line. You mark the initial you take your time. Okay, so I left at 7 o'clock. Okay. My initial. Okay. 20th, whatever it is. 20th, there we go. Alright, the 20th. So now, the next shift comes on. They've got that much. So what are they going to do? Say this is 100 ml. Close, but still, 100 ml, right? Okay? This line is
175.
So at 7 o'clock it was 100. At the end of the next shift, 3 o'clock, it's 175.
What's the output in that shift? 45 in this shift. Okay.
Basically, you make sure that you've documented so that the next person can figure out what their total is going to be. All right. Let's see. Next, you want to make sure you keep an occlusive dressing at the site of the chest tube exit, I guess, or insertion. Okay, an occlusive dressing at the insertion site. You also want to have sterile gauze at the bedside to cover the site immediately if the chest tube becomes dislodged. Also, keep chest tube clamps at the bedside for use only if the tubing becomes unhooked from the system, and we've even talked about that. They would recommend, instead of even using the clamps at all, what would we want to do? Have a bottle of sterile water, 250 ml bottle of sterile water at the bedside, so that we could immediately put it down about 2 inches into that water. And that's doing the same thing with that system. Okay? And then you holler for some help so that you can come in and get that changed out. Okay? Alright, everybody clear on that? Again, mark the drainage, check for kinks or loops in the chest tube, observe for appropriate titling. Now this is where the titling is going to be that you look for. What's titling? A constant movement of the fluid in the tubing. Okay, that's what you're looking for. You want to see that titling going on. Observe for air leaks. Do not strip or milk unless ordered specifically by the physician, and they don't necessarily want to do that anymore. What that does is that alters the pressure. If we strip it, try to get those clots out, usually it doesn't get the clots out. All it does is alter the pressure that's being placed on the lung, and it can cause further damage. Incentive spirometer for coughing and deep breathing is very, very important. What happens when you've got a chest tube in your lung? What do you think you're going to feel? You may feel the fluid. More likely it's going to be, what are you going to feel? Pressure and pain. Okay? But are you going to want to breathe in real deep and expand those lungs? No. You lose that drive because guess what? It hurts. Okay? The patient just does not want to breathe in as deep because it hurts. So what do? We make them do it. Using incentive spirometer, deep breathing exercises. We go in and say, hey, we've got to start breathing in deep. Make sure they breathe. Make sure they breathe in deep. Move that air in. Okay? That, for one, it'll help with the lung expansion process. We bring in more pressure, right? Bring in the pressure in the lung. It helps with that. Also, it prevents what? Pneumonia, pulmonary edema. Pulmonary edema is more of a different cause, but the pneumonia, all that fluid build up in the lungs because of infection, because of stagnation. Basically, everything's just sitting there, right? We want to keep them breathing, keep that air moving in and out. All right, some of the different types of respiratory failure. Respiratory failure itself is going to be a breakdown in the gas exchange process, resulting in hypoxemia and inadequate transport of oxygen into the cells. Okay, that's acute respiratory failure. It's acute, so it's a sudden, not expected breakdown in that gas exchange process. Okay. Now, there is specific criteria that we look for that would classify a patient in acute respiratory failure. Does anybody know what that's going to be? What's the PaO2 look like? Can be decreased. Does anybody know the number? Less than 60. There you go. Who said that? Less than 60. All right. PaO2 less than 60. All right. What else? All right. SAT's less than 90%. Any others you got over there? All right. CO2 greater than 50, and that's going to result in what? Acidosis. pH less than 7.34. Okay. All right. Y'all probably need me to repeat those. PaO2 less than 60, SATs less than 90, CO2 greater than 50, pH less than 7.3. That's what they really look at. 7.3 is when they really consider that respiratory failure. But regardless, it's respiratory acidosis, right? All right. That's kind of the criteria they look at for the respiratory failure. Some of the problems cause the ventilatory failure. And what's ventilatory failure? Oxygen intake. Okay? Oxygen intake means, well, we're not bringing in enough oxygen. So we have a ventilatory problem. Problem with ventilation. Yeah, that's yeah. That's very because basically with respiratory distress syndrome, well, what's the issue? Can't get enough in. Okay, you lose some of that compliance, you lose the ability to expand the lungs and ventilate. Okay, so COPD, asthma, CNS. Why would CNS be an issue that would lead to acute respiratory distress? All right. Yeah, if we have central nervous system depression, our brain is not working to tell us to breathe. All right, not adequately, and it could completely tell you to stop. I mean, not tell you to stop, but just stop that drive to breathe in. Spinal cord injuries, really things that are reducing that central nervous system function, neuromuscular disorders, pulmonary edema, all these are ventilatory failures. These are things that prevent us from being able to breathe in and bring in enough oxygen. Okay? The oxygenation is that gas exchange. Okay? There's a problem with perfusion, movement of oxygen into the capillary and bringing the CO2 out. Oxygenation failure. Okay, ventilation, we're bringing in all the oxygen we need. We just can't get that oxygen into the lungs into the circulation and the circulation out to the tissue. Okay. All right. Oxygenation failures occur with inspired air with less than oxygen or decreased oxygen concentration. So higher elevations. We go to a higher elevation, we're bringing in the same amount of air, but that air has reduced oxygen levels in it. Okay? That's an oxygenation failure. CHF with pulmonary edema. Okay? Why would that be an oxygenation problem? We got fluid backing up now, right? And it's our heart is struggling to move enough blood into the pulmonary system, pulmonary circulation, and move the pulmonary circulation blood out to the left heart, right? So we have a reduction in that circulation there. Decreased hemoglobin levels. Why would that be an issue for oxygenation? You can have all the air and all the oxygen in the world, but if you don't have the hemoglobin to transport it, it doesn't do you any good. Okay? Think of this, and this isn't talking specifically in terms of circulation out to the body, but the circulatory problems can lead to oxygenation failures. Okay? Does that make sense? We're not talking about a problem with the transport, but the transport problem could lead to an oxygenation issue. But regardless of the problem or the cause, the problem is always the same. We can't bring in enough oxygen, we can't oxygenate the blood. We can't perfuse the blood, oxygen into the blood, we still can't oxygenate the blood. So hypoxemia will always result from acute respiratory failure. Okay? That's still going to be the issue regardless of the cause. Alright. The acute respiratory distress syndrome. Okay? This is the result of inflammatory triggers that damage and collapse the alveolar and interstitial spaces. This is going to be due to a direct injury to the lung, such as trauma, smoke inhalation, aspiration, infection, or the disseminated intravascular coagulation, problem with the clotting cascade. Or it could be an indirect, including shock and major surgery. Okay. Regardless, these are the causes of the inflammation that triggers and damages the alveoli, interstitial spaces. All right. Know the manifestations. Ear dyspnea occurs 12 to 48 hours after the insult. Arterial hypoxemia, regardless of the oxygen amount. So we bump that oxygen up, keep bumping it up, keep bumping it up, and they're not getting any better at all. Okay. The lungs become stiff and non-compliant. They're not moving in to bring in air. They're not collapsing. They're not even collapsing, but they're not contracting to exhale. Get rid of the CO2. So our ABGs, we're going to have alterations that show decreased oxygen levels, or PaO2, that do not improve with oxygen administration. Now, what else do you think you would see from an ABG standpoint? We've got diminished oxygen. We've got decreased compliance in the lungs. Decreased oxygen, increased CO2. This is going to do what? Bring that pH down. Okay? So respiratory acidosis. Sputum cultures are going to be used to evaluate for the presence of infection. And then we'll get a chest x-ray to evaluate white, hazy appearances in the lung field. Real quick, I don't know if y'all are ready for another break. Alright. Medical management. Let's start with this. Let's start with our nursing home. Okay? Monitor and implement the medical plan of care. Okay? But first, even before that, what do we want to do? Patient positioning, raise the head of the bed. Okay? Psychological support, ventilator considerations. We want to maintain the airway. Okay? Maintain the airway, ensure adequate oxygenation, monitor them and implement medical plan of care. A lot of the medical plan of care is probably going to help with that. Right? Mr. Oxygen as ordered. We want to keep SATs above 90%. Nutritional support's a big one. You got all this part. Okay. Promote gas exchange. Airway and breathing is your big, and oxygenation is your big thing there. Okay. We got to make sure we maintain that. We do use that medical management to provide the nursing care. All right, now go take a break. Let's see. We got about 10:15. All right, so lung cancer. Okay. You know these manifestations. Persistent changing cough. A dry hacking cough that can change to productive, okay, as it progresses. Also, signs of chronic respiratory insufficiency. Dyspnea, cyanosis, clubbing of the fingers. Hoarseness, hemoptysis, okay, chest pain, diminished breath sounds. Reoccurring episodes of pleural effusion, pneumonia, or bronchitis. And non-pulmonary manifestations, including weight loss, fever, fatigue, muffled heart sounds, dysrhythmias. You need to know these. Okay? All right, so now, what are the manifestations of lung cancer? What are some of the key manifestations? Okay, weight loss, persistent cough, fever. What else? Hoarseness, Diminished breath sounds, chest pain, wheezes, okay, cyanosis, clubbing of the fingers. What else? Signs of respiratory distress, right? Dyspnea. Okay, good. All right, treatment options. Well, depends on the size, the type, the location, what structures are involved, all that good stuff. What do they want to do with it? Well, they could take off a whole lobe. They could take off a whole lung. They could take off a piece, segmentectomy. You know, it just depends on where the problem is, okay? Non-surgically, they could do chemo, radiation. That's not necessarily, you don't need to necessarily worry about which different type is going to be used, okay? But your care, well, what would your nursing care be for any of these on the surgical side? They come out, airway, breathing, yeah. Okay, now specifically for the lung surgery, what else? Okay, monitor hemorrhage. What else? Infection, wound care, pain. Most likely they're probably going to have chest tubes, so management of chest tubes. Okay. You need to prepare for that, and really it doesn't really matter what type. Now, obviously a pneumectomy, they're probably not going to be doing a chest tube, right? They don't have that long now. All right, but you're still, the airway, the breathing, the circulation, the infection, the risk for hemorrhage, all that good stuff is still there. And the nursing care is going to be similar, right? You're still going to have those same plans that you have to kind of follow regardless of the type. You need to be aware of the different types, but your nursing care is not necessarily going to change drastically. Okay? All right, now let's get into asthma. Okay. Asthma, what is important on this page? Well, it's intermittent and reversible, right? Leads to acute airway distress that affects the airways, not the alveoli. That's important to know. Okay, it's an airway problem. Closure of the airways is your issue. It could result from a number of different things. From inflammation, from allergic triggers, from infection, all kinds of stuff. But your treatment's still going to be pretty similar, right? What are we doing first with an asthma patient in an acute asthma attack? Okay, well, yeah, set them up, okay, and probably going to help. But if their airway's closing, is that going to help a whole lot? Probably not. So what do you need to do first? Okay, if they haven't taken a respiratory inhaler, they need to do that, okay? But now, there are some cases when that may not be. Say a patient comes in an acute asthma attack and they progress to a certain point. Are you going to be able to just take an inhaler and have them puff on it? Could be a nebulizer. All right, what do you have to do first to figure out what you're going to do? You need to assess, right? All right, kind of assess the situation. Now, what are you looking for? O2 stats. Okay. Wheezes. I would say let's listen, right? Let's listen. See if we can hear. What can we hear? In an acute asthma attack, what would we expect to hear? We would expect to hear wheezes. Now, if we've got a patient coming in on an ambulance, we know they're having an acute asthma attack, and now we don't even hear wheezes. What do we have going on? We got respiratory distress to the point that now we're not going to be able to just puff an inhaler in their mouth. We can't just give them an albuterol inhaler real quick and they're done. That's, at this point, what do we have to do? We got to prepare for what? Intubation. Intubation, and if they can't intubate, we got to be ready for a trach, right? We've got to do something to establish that airway. So be careful with, and yeah, raising heavy beds is an answer on a lot of it, right? But you also kind of need to assess and figure out, okay, what's going on with this patient. If raising the head of the bed doesn't work, what do we got to do? Now, on this patient that just came in an emergent type situation, is it going to matter? We could put an O2 sat on them. Is that really going to tell us a whole lot? No, I mean, it just tells you they can't breathe. If you can visually see they can't breathe, an O2 stat is just going to confirm that. You got to figure out what can you do first to help them breathe. All right, let's see. These are some acute but some chronic of clinical manifestations of asthma. The audible wheeze, increased respiratory rate, signs of respiratory distress. They're going to be the same. Tachycardia, increased respirations, retractions, use of accessory muscles. They physically or they verbally say, "Hey, I can't breathe." Or they cough, or they turn blue, or they turn pale, all that good stuff. It's all going to apply. Okay? Some of these chronic things, including barrel chest with air trapping, or from the air trapping, long breathing cycles, cyanosis, hypoxemia. Okay? Some of those are acute, some of those are chronic. Some of the drug therapies. Drug therapies are usually going to be based off of or on, for that specific patient, different severity levels. Okay? Usually you're going to have the green, the yellow, the red levels based on their peak flow meter readings. Okay? What's the percentage that they are at this point from their normal baseline? What's the typical medications that we'll use? What do we normally do? In an acute attack, what are we going to do? Bronchodilator, the short-acting, right? What's probably the most typical short-acting bronchodilator? Albuterol. This patient that came in borderline unresponsive, but we're not even hearing wheezes anymore. Are we really going to be able to do much from the breathing? What would we probably do? Okay, intubate, and if we were going to do something IV, what would we give, you think? Epinephrine. We're going to give some kind of, the quick-acting IV bronchodilator, basically. Okay? Epinephrine, we can do it. If we're not moving air into the lungs, the nebulizer's not going to move it in, right? So we could give something IV in that situation. Let's see, what else we got? We've also got, oxygen. That's another one. Should have started with oxygen. We try to give them some oxygen as much as we can. But again, if they're not breathing in, they're not taking it in. But oxygen is very important. Albuterol is a short-acting. That's probably your most common. Also, Zopinex is another one of those short-acting beta-2 agonists. So we've got a beta-2 agonist. What's important about that whole agonist part of it? It stimulates that beta-2 receptor, right? So if we stimulate that beta-2 receptor, we're going to get bronchodilation, but also what are we going to get? Okay. Heart effects. Now, what are the heart effects going to be? Increased heart rate, increased blood pressure. Okay? It affects the heart. Think of it in this term. Okay, so what are all those symbolic of? So if we've got bronchodilation, we've got bronchodilation, vasoconstriction, which is increased blood pressure, and then also increased heart pumping, so heart rate. What are those? When does that happen? When do those three things happen? Okay, when we stimulate the sympathetic nervous system. So these are things that, when that fight or flight response is initiated, we want to be able to breathe in deep to get more oxygen in. We want our heart to beat faster and more frequently so that we can oxygenate the tissues, right? So these are sometimes outside side effects and complications that can occur, not even complications, but these are things that can also occur when we get our vasodilation, or I'm sorry, our bronchodilation that we want. Does that make sense? So yeah, we want the bronchodilation. We want the increased breathing, increased airway area, but we also have to monitor for this increased heart rate, increased blood pressure. Because if the patient already has increased blood pressure, and we increase it even more, we could have some real problems. Okay, but again, airway's going to come first, but you still have to consider that. Now, okay, we've got a patient on, well, our maintenance drugs. What are some of our maintenance drugs? Okay, anti-inflammatories. Okay, what else? Corticosteroids. Any other? Okay, we got the long-acting bronchodilator. Okay, anticholinergics. All right, so what are these? What's the function of these maintenance drugs, just as a group? To prevent and keep us on a nice, in a nice level to where we're not having the asthmatic symptoms, right? Our maintenance drugs should be given when? Every day. They don't need to miss them, right? This is not something that they give as needed. Okay? So when you educate your patient on maintenance drugs, preventative drugs, what do we do? Or what should be included in your education? Compliance. Make sure they take them when they're scheduled, as the physician ordered. Whether they've said anything about it or not, go ahead and tell them, look, take these every day. It doesn't matter if you feel like you need them or not. Okay? Educate them on the rescue drugs. Rescue drugs need to be initiated when we start having the symptoms, right? Hopefully, and I don't think I have this one. Actually, I do. When you're looking at your peak flow level, we don't need to wait till they get to the red zone, right? We don't need to wait till they're less than 50% of their normal peak flow value. We want to hit them in the yellow zone, right? 50 to 80%. So come on in. All right. So hit them in the yellow zone. What's the goal? Yeah. Put them back to the green zone. Okay. Evaluate these levels. All right. Make sure they know how to evaluate and what to do in those different levels or categories. All right. That's the big thing there. But they're going to tailor it to the patient. Yeah, and that's the thing about most of the asthma levels. It's going to depend on the patient, the severity of the patient's condition. The medications are going to be tailored. Even the peak flow. Okay, these peak flow readings. We're going to look at their baseline. What are they normally at, and then alter based off of that. That's usually where the different categories are going to come from. But it's going to be spelled out specifically. When you reach this level, this is what we want you to do. When you reach this level, this is what we want you to do. The goal is to prevent the status asthmaticus. Okay? We want to prevent the severe, life-threatening acute airway obstruction. So the patient came in lethargic, unresponsive. They've lost all airway movement in the lungs, or you're not hearing anything. That's the patient that's gone into this status asthmaticus. And the only thing in this case, well, we've got to give them some oxygen, but even then, if they're not moving air, oxygen's not going to do them a whole lot of good. We've got to establish an airway first. Okay? Now, I think I kind of skipped. Not necessarily. Status asthmaticus is when they've been in that red zone and they're still, they've probably been in that red zone for a while. All right. Now, COPD. Let's talk a little bit about COPD. COPD, the tissue damage is not reversible. And it's not just affecting the airway. It is affecting the airway, but it's also affecting the alveoli in that gas exchange process. Okay? Non-reversible, increases in severity, and will eventually lead to respiratory failure. All right. Now, the treatment's going to be pretty similar to asthma, right? We're still talking about the bronchodilators. Okay, they may still have with COPD. It's more of a management of the symptoms. Hopefully, improvement of not just we're not going to be able to treat the overall problem and cure the COPD. Okay, we're going to manage the symptoms and try to prevent the exacerbations as much as possible. Okay, so these interventions include oxygenation, improve oxygenation, and reduce CO2 retention. Hopefully, without the use of oxygen therapy, if we can help it. Okay, place the patient in an orthotic position. What is that? It's an orthotic position. Sit them up, head of the bed up. Put some pillows behind them, even leaning forward. Okay, even leaning toward the tripod position. Allow them to get comfortable with the head of the bed up, and this will improve not only the oxygen intake but also the CO2 removal. Prevent weight loss as much as possible. How can we do that? Prevent weight loss. Frequent small meals. Yeah, frequent small meals. High calorie, high protein meals in short intervals. Okay. What else related to that as far as activity goes? Rest periods between activities. Okay. Particularly in the hospital setting, because we want to work with. It's not just our care. We've got to collaborate with who else? Physical therapy, occupational therapy, which is a big one. Occupational therapy. Speech therapy, whoever. May or may not have speech therapy, but definitely PT and OT. You really need those. What is occupational therapy going to help with? ADLs. Okay? And we're not, occupational, yeah, some of it may be occupational therapy to get them back to work, but a COPD patient may not necessarily be back to work, but just to be able to survive or live on their own or as best as they can independently. Those are kind of the goals there. We also want to prevent respiratory infection. What is infection going to cause in a COPD patient? It could be, pneumonia, but it could cause what? Respiratory distress and an exacerbation of those symptoms. Okay. The medications are going to be really similar. Manifestations. Through manifestations. We've got repressive fatigue, lethargy, nausea, anorexia, weight loss, irregular menses. Oh, we're moving to TV. What do you say? We're still talking about irregular menses. Okay. Oh man, we've gone somewhere else. All right. So the drug therapies, manifestations of infection, breathing techniques, and relaxation therapy. They need to know what they need to report to the physician. Okay? They need to know what things, or what the recognition of respiratory distress for one, and a worsening of the symptoms so that they can treat it early. Once the infection is, usually if they can treat the infection quick enough, they can prevent that exacerbation. If not, usually they're going to be sick for a while. And we also want to prevent the worsening of the symptoms that lead to oxygen therapy as well. And we talked about that quite a bit earlier. Okay. Okay, TB. Now we'll go to TB. TB, what's TB? Tuberculosis is an infection, right? So why is it a problem? What's the thing that kind of scares us a little bit about TB? It's highly communicable by airborne route. Okay? So, if you have a patient that you suspect the TB that comes into the emergency room, what are you going to do? Isolation precautions. What type of isolation precautions? Airborne precautions. Okay, so when you walk into that room, what are you going to do? Well, what type of mask? N95 respirator mask. Okay? All right, what else? Anything else? Yeah, they need to be in a negative air pressure room. Absolutely. They need to be isolated. We talked about that with isolation precautions, but they need to be by themselves. We're not going to put them in somebody else. I guess unless it's a TB positive patient. But that's the thing. All right, so let's see. What else? What are our treatments going to be for our TB patient? Okay. Drugs? Yeah. What's going to be first? Yeah. Isolate and maintain the respiratory issues, right? Okay. So it's airway breathing. They're not usually going to be in too bad of an acute shape, but we do want to monitor that. But then the medications, okay, and this is going to be a big part of it. The medications, okay. What's important about the medications? Adherence, compliance, extremely important. Why would a patient not want to be compliant with these TB meds? All right, I heard some. Okay, the complications, okay, liver damage, okay, and what could make that liver damage risk worse? Drinking alcohol. So a lot of patients, you tell them, hey, you can't drink with these medications, and they'll say, I'm not taking it. Right? I don't care, I'm not going to take it. So you got to figure out what the problem is. You know, if a patient comes in non-compliant and they're not getting better, and you ask them, are you taking your meds, which needs to be one of the important things that you ask for that patient. If you're in a clinic or even a hospital, they have an exacerbation of symptoms, are you taking your meds? Are you taking them as prescribed? And if not, why are you not taking them? Simple question. You don't have to be accusatory or anything like that. You just say, is there a reason that you're not taking it? Why would we want to make sure we know why they're not taking it? Because some of the concerns may be due to these complications we want to watch for, right? Okay? If they start having vision problems, you may have a patient that just says, hey, I can't see anymore with those medicines. I'm just not going to take them. I'm not going to necessarily report it. I'm just not going to take it. So find out why. You may have a patient that says, well, I started having liver issues and somebody called me or said that I looked yellow. Well, that's a concern we want to know about. Because we can alter the medication from a medical standpoint anyway. They can go in and they can, look at the different medications and change them up. What about which medication might cause body fluid changes? Yeah, orange sweat, orange urine, rifampin. Rifampin is going to be the big one, okay? Rifampin. All right, rifampin may cause orange, reddish discoloration of the sweat, urine, all the body fluids. Okay, yeah, that could really freak out a patient, make them not want to take it, right? In a hurry. All right. Now, if you've educated them prior to going home with that medication, that helps sometimes, so they're expecting it. All right, now 2 to 3 weeks. Patient's no longer contagious, right? That's what we said, 2 to 3 weeks. Do they need to stop taking their medication? No, absolutely not. After 2 to 3 weeks, the patient's probably going to feel better, right? You think they may just say, well, I don't need to take those medications anyway. I feel better. Same thing with antibiotics. We want to make sure we educate them. You will feel better and you will no longer be contagious after this time frame, but you've got to keep taking the medication. Okay? Those nasty, really resistant bugs down in there are going to be a lot more resistant and stronger. And when you stop taking your medicines, they're going to get stronger and they're going to replicate. Then you got a really bad TB case. All right, now, this patient that has had TB in the past, they've taken their medications for 6 months, everything's good. Can I give, or well, would a PPD or Manitox test be effective on them? No. So what's it going to show? It's going to show positive. Okay. Does that mean that they are in an active infectious TB state? No. That does not mean they are active. They have active TB. What does that mean? They've been exposed, and now what's happened? Possible. It could be they have active TB, but more likely they have antibodies, but even more, they have encapsulated TB lesions. It's dormant inside their lungs. Okay? Now, if I give this patient an immunosuppressant drug, what may happen? It could reactivate because it's still kind of there, but it's dormant right now. But it could reactivate. Okay? What would be the test that would help to confirm whether it's active? Chest X-ray that allows us to evaluate the presence of those lesions. Okay? Also, what could we do? What could we do to evaluate for diagnosis? Sputum culture. Okay? Sputum culture is also something that we could do to evaluate that as well.